Yeah, I hope all of you can see the screen.
It is visible.
Yeah. So yesterday we discussed rectum and anal cancers. Today we are going to talk about prostate cancer. Both of them all of these are pelvic malignancies, and many of the things are common. So it'll be easier to, do this today because many of the anatomical issues are known. So the agenda today is to give a very short overview of the management. Go over very quickly the prostate anatomy and staging and the target volumes for radical treatment, and then the target volumes for adjuvant and early salvage radiotherapy. Now, if you look at the treatment overview of prostate cancer in one slide, prostate cancer first has to be staged, diagnosed and staged. And the common investigations at the moment that are done is a truss-guided biopsy, a PSA test, a multiparametric MRI, and either a bone scan or a prostate-specific membrane antigen or PSMA PET-CT scan. Once these are done, we generally divide non-metastatic or prostate cancer without distant metastases into low risk, intermediate risk, and high risk, as well as node positive disease. So if you've got pelvic nodal metastases but no other metastases, that category is the node positive prostate cancer. Now, if you see what the treatment options are for low risk prostate cancer, preferred treatment option at the moment is active surveillance. But patients who are not keen on active surveillance, cannot do repeated investigations, are not good for follow-up, can be taken up for either radical prostatectomy or radical radiotherapy. For intermediate risk disease at the moment is also further subdivided into favorable and unfavorable intermediate risk disease, depending on whether the Gleason score is 3+4 or 4+3. And in intermediate risk disease, you have you do have to treat the patient, and you could either treat the patient with radical prostatectomy or with radical radiotherapy. Both are equivalent options, and ideally, a patient should be seen by a urologist and a radiation oncologist, and the pros and cons of each approach discussed, and the patient can then decide. For high-risk prostate cancer, which is either a T3 or T4 disease or Gleason score of 8 to 10 or PSA of more than 20, in such risk disease, I would say that the preferred approach would be radical radiotherapy with androgen deprivation therapy. But more and more with the availability of more sophisticated surgical techniques like robot-assisted radical prostatectomy is also one of the options. For node-positive disease, clearly radical radiotherapy with androgen deprivation therapy is the main option. Earlier, people were treated with androgen deprivation therapy only, but there has been great value found in the use of radical radiotherapy, so in addition to androgen deprivation. Now, for those who do undergo a radical prostatectomy as the first treatment, depending on what the pathology is and what the post-operative PSA is, some of these patients will become candidates for either salvage radiotherapy or adjuvant radiotherapy. We are going to discuss a little bit more about indications later on. So what does this slide really tell you? What this slide tells you is that for prostate cancer, if you look at the one treatment option that fits practically every single category of disease, of non-metastatic disease, it is radiotherapy. So radical radiotherapy can be used as a curative treatment option, starting from low risk to intermediate risk to high risk to node positive, and as well as post-operative treatment. So it is very important, as Dr. Gunaseelan mentioned, that prostate cancer is an increasing, chronic health problem. Therefore, it is very important for us to understand radiotherapy for prostate cancer very well. We are not going to discuss treatment, evidence and rationale and etc. in detail today because there's not enough time. So let us go into how to delineate targets for prostate cancer. So we'll start with target delineation for radical treatment. Now, before we go in directly into target delineation for radical treatment, we need to see what are the guidelines. Are there guidelines available? Yes, there are. But compared to post-operative treatment, the guidelines available for prostate cancer radical radiotherapy are relatively few. So we have an old guideline from the EORTC from 2006, and we have a more recent guideline from ESTRO-ACROP published in 2018. Now, before we go into these guidelines, let us take a quick look at what are the structures that we are going to discuss today. Now, most importantly, we have to look at the prostate. But apart from the prostate, there are some contentious problem areas that we need to be very clear about when we contour prostate cancer. The most important one is the prostatic apex, followed by the penile bulb, which is not really a prostate, but it's something that you need to identify properly if you want to delineate the target volumes of the prostate properly. We also need to understand the seminal vesicles, when to treat them and how much. We need to discuss whether we need to give any margins around the prostate or not. We then need to discuss what is the role of elective nodal radiotherapy, if any, and what are the PTV margins that we want to use, and how do we draw the rectum. Now, a short detour into anatomy. We all know that just like rectal cancer, for a proper delineation of prostate cancer, we need to look at MRI images. And again, just like rectal cancer, the sequence that we are interested in is the T2 weighted MRI sequence. And again, diffusion weighted imaging is important. Dynamic contrast is important as a component of multi-parametric MRI images. But the most important thing for us as radiation oncologists is really the T2 weighted MRI image. Now, if you look at the diagram on the right, you will see that the prostate has several parts, the prostate gland. Now, if you look at it from anterior to posterior, the anterior part is a fibromuscular stroma. Okay, there are no glands in this part, and this part usually appears, dark in the T2 weighted MRI. Behind the anterior fibromuscular part, there are two zones: the transitional zone, through which the urethra passes, and the central zone, through which the seminal vesicles and the ejaculatory duct enter the urethra. So you can appreciate the 3D anatomy of this area, and this area usually has a heterogeneous appearance in relatively older people, because benign prostatic hyperplasia generally affects these areas. Behind these two zones, circling it like a C or a kidney-shaped manner, is the peripheral zone. It is in the peripheral zone that 3 out of 4 prostate cancers arise, and it is this zone that we are most interested in. Now, if you look at the MRI, you will see that the peripheral zone has high signal intensity when it is normal. So it looks whiter than the transitional zone, which looks darker. However, when there is a prostate cancer in the peripheral zone, there will be hypointensity in this area. So the prostate cancer bearing areas will appear darker. So this is an important thing to understand, because we need to identify the region where there is prostate cancer in the MRI images if we are to contour properly. Now, how do we know the borders of the prostate gland on CT and MRI images? When we want to draw the CTV of the prostate, where do we draw it? Now, if we are going to look at the CT, only the CT, to draw the target volumes, Anteriorly, we must include the anterior fascia, but exclude the fat in front of the anterior fibromuscular stroma, unless there is protrusion of the prostate on the CT, of the prostate cancer in this region on the CT scan. Similarly, if we are using MRI, now how many of us use MRI? I think that a proper MRI fused prostate cancer radiotherapy is generally rarely done. And to my mind, it's not really that important unless we want to give radiotherapy with very small margin. Now, in our practice at Tata Medical Center, we usually look at the MRI, but we don't fuse the MRI with the CT. So we generally look at the MRI, we find out which regions have the prostate cancer, we read the MRI report, we see whether there's any extracapsular extension, we see whether there's seminal vesicle involvement on the MRI. So if those are not involved, if there's no anterior extension, we leave that anterior extension out. Laterally, of course, it's very important to identify the levator ani muscles. We're going to look at the anatomy very shortly, the radiological anatomy and the targets very shortly. But we are so laterally it is bounded by the levator ani muscles. Posteriorly, generally it's the anterior wall of the rectum, which is the margin of the prostate gland. Now, as I mentioned, the prostatic apex is a very, very contentious area. What is the apex? The prostate is like an inverted triangle. So the apex, or the inverted pyramid rather, okay? So the apex of the prostate is the lowermost portion of the inverted pyramid. Now, since most of us contour a prostate cancer on a CT scan and not an MRI scan, the exact caudal extent is really often very difficult to assess because there's really no difference between the prostate gland, the urogenital diaphragm, and the levator ani muscles at that point. So it is interspersed amongst the fibromuscular tissue of the pelvic floor. Now, several studies have been done which have looked at how the prostatic apex is related to other more easily identifiable structures. So the most commonly used structure to assess where the apex of the prostate gland is the penile bulb. So if we can identify the penile bulb properly, and we are coming to that in the next slide, we can get a pretty good idea as to where the prostatic apex is. Now, generally, it has been shown from numerous MRI studies that the prostatic apex is usually about 1.3 centimeters above the penile bulb. Therefore, if we contour from 1 centimeter above the penile bulb, we can be confident that we have covered the prostatic apex. There have been other anatomical structures that have been used as a proxy for identifying the prostatic apex, which include the obturator foramen, so about 1 centimeter above the obturator foramen, about 3 centimeters above the ischial tuberosities, or about 0.7 centimeters above the bottom of the symphysis pubis, are other reported proxy landmarks for the prostatic apex. Now, in our practice at Tata Medical Center, we identify the penile bulb and then we go centimeter. Now, to go up 1 centimeter, you need to know how many cuts you've taken in your CT scan. So if you've taken, like in our practice, we usually take 2.5 millimeter cuts. So we generally go about 4 cuts above the penile bulb to reach what is known as the lower border of the prostatic CTV, covering the prostatic apex. Now, as I mentioned, in order to identify the prostatic apex, we need to identify the penile bulb properly. So what is the penile bulb? The penile bulb is simply the proximal part of the corpora spongiosum of the penis. So if you look at the MRI scan on the right, you will see that it is very easy to identify on the MRI. and actually not difficult to identify either on the CT scan. So at the mid portion of the penile bulb level, this is what the penile bulb looks at like on the CT scan. So it's kind of a teardrop shaped structure, and if you start contouring from this level, you will be able to go up and see where it ends. So this is an MRI, some MRI cuts in the coronal and sagittal plane, which demonstrate what these structures are at this point. So this is the penile bulb. Above that is the urogenital diaphragm, and then starts the prostate gland. So this span between the upper part of the penile bulb and the lower part of the prostate gland through the urogenital diaphragm is slightly more than a centimeter. So if you start contouring about a centimeter up from this area, you will cover the prostatic apex properly. Now again, these are corresponding CT and MRI sections of the penile bulb. So as you can see, this is the mid bulb region, and then if you go up, you will be able to see where the penile bulb ends, and corresponding cuts on the CT scan. So at about this level, the penile bulb is over. So you generally go about a centimeter above this to identify the prostatic apex. Now, it's very common to have very oddly shaped prostate contours when we are a little less experienced in contouring the prostate cancer. And this is a very beautiful paper by McLaughlin and colleagues from Providence, from Ann Arbor in Michigan, which show the radiographic and anatomic basis for contouring errors of the prostate. So I would strongly recommend you take a look at this paper. And what this paper shows, it's diagrammatically, it shows you how we usually go wrong. Okay, so this is without any boundaries drawn. This is with the correct boundaries drawn. So this is the prostate gland, this is the urogenital diaphragm area, and this is the penile bulb. Now, very often when we start contouring, when we are a little less experienced, our prostate contours can look like this in the coronal plane, in the sagittal plane. So we've taken too much, we've contoured too much into the urogenital diaphragm, and we've kind of reached the penile bulb. Okay, when we contour like this, we are giving an unnecessary dose to the urethra in the urogenital diaphragm and increasing the risk of getting a stricture later on. Similarly, if you look at D, E, and F, these are also common mistakes. So you kind of come out posteriorly, but we are still going down. It's kind of a pear-shaped structure with teardrop shape pointing down. This is another wrong contour where you've gone very close to the rectum posteriorly and gone into the fat between the prostate and the rectum. And sometimes we take an unnecessary part of the seminal vesicles. We'll cover the seminal vesicles and its rationale very shortly. Another common mistake is to go too much into the bladder wall anteriorly, because even on a CT scan, it's sometimes quite difficult to identify where the prostate anteriorly ends and the bladder wall begins. So if you go too much into the bladder wall, you're going to unnecessarily treat a part of the bladder when we expand the PTV margin. Conversely, it is also possible to miss the base of the exact extent of the base of the prostate. So sometimes the base of the prostate projects into the bladder. So it's very important for us to identify this part and contour it in a proper way. So we are now going to discuss the seminal vesicles. We are going to discuss all of these theoretically, but then we are going to then take a look at some of these on a demo case. Now the seminal vesicles are, again, invasion of the seminal vesicles with the cancer when we look at it on the MRI, it has a very high specificity, but its sensitivity is not so high. Okay, so which means that there will be cancers where the seminal vesicles look perfectly normal. In about 40% of the cancers where seminal vesicles are involved, the MRI may not be able to pick it up. Okay, but if the MRI picks it up, it generally means that the seminal vesicles are involved. So because it has a relatively low sensitivity, we often have to contour the seminal vesicles decided on by other parameters. And these are generally, the Gleason score and the PSA, and we use the Roche formula to calculate. So in our, usual practice in India, when we see prostate cancers, which are generally a bit advanced because we don't have a screening program, the chance of having seminal vesicle involvement is relatively high. Now, how far into the seminal vesicle do we really need to go? Now, there have been several studies again looking at the pathological analysis of radical prostatectomy specimens, which show that the seminal vesicle involvement is most often restricted to the proximal part. Now, of the two contouring guidelines, in the EORTC guideline of 2006, what they recommended was a proximal 1 centimeter for intermediate risk prostate cancer and 2 centimeters for high risk prostate cancer. The ESTRO guidelines of 2018 have modified it to include proximal 1.4 centimeters and 2.2 centimeters for intermediate and high risk disease based on further studies that have occurred between 2006 to 2018. So without going into too much detail, because we've just got an hour, so we can't really discuss all this evidence in a lot of detail, but just for you to remember that it's important to cover a part of the seminal vesicle in both intermediate and high risk disease. For intermediate risk disease, we capture about 1 centimeter, and for high risk disease, 1 to 1.4 centimeters, and for high risk disease, 2 to 2.2 centimeters. The next question that we have is, do we need margins around the prostate gland? Now, usually, for practically every other cancer, we have a GTV volume, and then we have an expansion into a CTV volume. Because we know that it's very difficult sometimes to appreciate extra prostatic extension or, disease going outside the capsules of organs. However, what's different about prostate cancer is that margins around the prostate are not commonly used in clinical practice. However, if you look at the EORTC guidelines of 2006, they did recommend using margins, but those are old guidelines for a time when there was no IMRT, no 3D. So basically for conventional treatment planning, where you needed to use slightly bigger treatment fields to make sure that even without IGRT, you're covering the target. Now, what does the current guideline tell us about margins around the prostate? So we know that if there is no extra prostatic extension, so if it is a T2 disease, then we do not need to do a margin expansion. If it is a T3 disease, then if you are using the MRI to contour, then it is easy to identify the region of the extra prostatic extension and no separate margins are required. If you're just doing CT-based contouring, the ESTRO guidelines suggest a 3 millimeter margin all around. However, you remove the rectal place where it is, going into the rectal wall. Now, what do we do? What do we do in clinical practice? In clinical practice at Tata Medical Center, we do not give a margin. However, we look at the MRI very carefully and make sure that we cover the region of the extra prostatic extension. So usually, all our patients would have an MRI, and we would make sure that in the region of the extra prostatic extension, we have looked at the CT scan carefully, and we've made sure that we are not missing in that area. What about nodal radiotherapy for prostate cancer? Now, nodal radiotherapy for prostate cancer is a highly, highly controversial subject. Okay? Because there's no clear evidence or very hard evidence of the benefit of nodal radiotherapy in prostate cancer. Does nodal radiotherapy help? We know from evidence that approximately 25% of radiologically node negative patients have pathological disease when they undergo an extended pelvic nodal dissection. So a number of people do have nodal metastases. And there have been retrospective studies which have shown the benefit of giving whole pelvic radiotherapy in patients with high risk of nodal metastases with the Roche formula or patients in high risk category. However, if you look at the 3 randomized control trials that have tested this, all of them have failed to demonstrate a clear benefit. It started several years back with the RTOG 7706. This was followed by the RTOG 9413, which in its first analysis showed that there was a benefit of giving whole pelvis radiotherapy, but in its final analysis with longer follow-up, there was no benefit of giving whole pelvis radiotherapy. The GETEC trial was the French trial and the GETEC 01, and that again failed to demonstrate any benefit of nodal radiotherapy. So as it stands today, the randomized control trials have not demonstrated benefit of nodal radiotherapy, elective nodal radiotherapy in prostate cancer. However, doctors don't seem to be very convinced about this, and they, in clinical practice, whenever in several hospitals in the North America, in US, Canada, in several hospitals in India, and in some hospitals in the UK and Europe, they still practice elective nodal radiotherapy. And this comes from a belief that we know that in high-risk prostate cancer, the chances of, as I mentioned, there's a 25% chance of radiological node negative patients being pathologically node positive. So it's pretty common practice, even without there being clear demonstrated evidence of giving elective nodal radiotherapy. And there are still ongoing studies. So, it seems that the prostate cancer radiotherapy doctors are not really convinced about these 3 randomized control trials. So there is the RTOG 0924, which is a new trial from RTOG, which is looking at pelvic nodal radiotherapy in high-risk prostate cancer, the UK pivotal trial. And in India, the Tata Memorial Hospital in Mumbai recently concluded a randomized control trial known as the POP-RT study, which is going to be presented in ISRO 2020, just in a few months from now. And we are eagerly awaiting the results of that study because this is in the Indian population, and it might show a benefit, perhaps, of elective pelvic nodal radiotherapy. Now, if you're asking about the benefits of nodal radiotherapy, you also have to ask about the toxicity of nodal radiotherapy. Now, the RTOG 9413 showed that what happens when we treat the nodes, we generally go up alongside the rectum for a higher, longer distance. And therefore, it is expected that the GI side effects of nodal radiotherapy are theoretically what is supposed to be high. Now, this was correct in the RTOG 9413 study, where a higher grade 3 acute and late GI toxicity was slightly higher. The absolute numbers were low, but proportionately compared to the prostate-only radiotherapy, it was higher. However, in the French study, there was no difference in the GI toxicity or in the GI-related quality of life. Interestingly, the POP-RT study, the Indian randomized control trial from Tata Memorial Hospital, showed that there was an increase in late genitourinary toxicity, mainly bladder toxicity in terms of hematuria and bladder symptoms. And this was reported, I think, last year or early this year in one of the papers in the Green Journal. So if we are going to treat the nodal volumes, how do we treat them? Now, we have the RTOG consensus statement, which is the most commonly followed. And here, what the consensus says in very brief is to start at the L5S1 junction, to commence contouring the CTV at the L5S1 interspace, go along the internal iliac and the external iliac vessels with a 7 millimeter margin, carving out the bowel, bladder, and bone. Also contour the presacral space from S1 to S3 with a 10 millimeter strip anterior to the sacral hollow. We stop the external iliac nodal contour at the top of the femoral heads, which is the bony landmark for the inguinal ligament, and stop the obturator nodes of the internal iliac contours at the top of the symphysis pubis. Now, the UK pivotal study, before it rolled out the study, when it was looking at its own, protocol for contouring, it did a very detailed analysis of previously published nodal volumes, and they have slight differences from the RTOG 9413, which shows that the superior extent of the lymph nodal CTV is at the L5S1 level, but because it's difficult to say it's L5S1, where do we exactly start? They suggest that the lower border of L5 on sagittal CT, the inferior extent is 1 centimeter above the top of the symphysis pubis instead of the top of the symphysis pubis, usual 7 millimeter margin over the vascular structures. You avoid the bowel, bladder, and bone, but also they have a 3 millimeter bowel expansion volume with which to avoid. Connecting the internal iliac and the external iliac nodes, the RTOG protocol says connect them, but doesn't specify the details on how to connect them. And the pivotal study says connect them with an 18 millimeter strip medial to the bony pelvis, including the small vessels in the contrast-enhanced planning CT. The presacral space is S1 to S3 with a 10 millimeter strip here. It's a 12 millimeter strip in the UK contouring guideline. And the caudal extent is at the top of the femoral head. So with all this, now what do we do at Tata Medical Center? Now at Tata Medical Center, looking at all these things that we've discussed so far, we, you would know that we have been practicing moderate hyperfractionated radiotherapy for many years now. And so our standard dose is 60 gray in 20 fractions, but we also do SBRT to a dose of 36.25 gray in 5 fractions once a week. So for low-risk disease, in the few patients that we treat for low-risk disease, it's the entire prostate gland and no seminal vesicles are contoured. For intermediate risk disease, the entire prostate gland and proximal 1 centimeter of bilateral seminal vesicles. Earlier, we used to treat the entire seminal vesicles to make it simple, but now we've restricted ourselves to 1 centimeter. For the high-risk prostate cancer, it's the entire prostate gland and the entire bilateral seminal vesicle, and also for node-positive prostate cancer. We do treat elective pelvic nodes for high-risk and node-positive disease. So this covers the periprostatic nodes, the presacral, obturator, internal, and external iliac nodes. The upper border in high-risk node-negative disease is the L5S1, but for the node-positive disease, we take the upper border higher up to the bifurcation of the aorta, going by our experience of failures in node-positive prostate cancer. Now, the lowermost axial section will be at the level of the superior border of the symphysis pubis, and similarly over here. Now, let us take a look at one case, just like we took a look at a case yesterday. So I'm just going to stop sharing this particular screen and shift to a different screen. Right, so I hope all of you can see my screen. Now let us take a look at, what are how to contour the prostate gland. Now, as I mentioned, we generally start so first what we do is that we identify the penile bulb, okay? And once we've identified the penile bulb, we take our thing about centimeter above, and we start contouring the prostate gland. We don't go into the levator ani muscles in the side. Let me see. We don't go into the anterior fat, and posteriorly we are at the rectum, the anterior wall of the rectum. Now, as we go further up, it's important to understand what to do in an area like this. Now, if I switch this off, you will see that we often face an issue with a structure like this. This is the bladder, but where is the prostate gland over here? So what we do is that we leave out a thin strip of tissue over here and contour the rest within the prostate contour. Okay. Now, as far as the seminal vesicles are concerned, in this particular case, which was an early high risk case, we covered the entire seminal vesicle. If this was an intermediate risk case, we would stop at about a centimeter, centimeter and a half. So the lateral parts of the seminal vesicle would be left up. Okay, so it's important to understand some of the muscles of the perineum. So let's take a quick look at the so this is the obturator internus. This is the pelvic floor musculature, which is formed by the levator ani muscles. This is the red one is the iliopsoas. Okay, so it's important to differentiate these structures from the prostate gland when we draw it. Now, for the nodal volumes, let me start from the top. So we are starting at the L5S1 interspace. This is a node negative prostate cancer. We identify the external and internal iliac vessels. So I'm going to external iliac, internal iliac. ठीक है. Okay, so as you can see, these are the vessels, and we've covered them with a 7 millimeter margin. We've taken a anterior, 1.8 centimeter, 12 millimeter strip. And then we continue going down. Now, the external iliac contour will stop here because we've now reached the top of the femoral heads. And the internal iliac or the obturator nodes will continue till we reach the top of the symphysis pubis. Now, in the UK contour, as I mentioned, they stop not at the symphysis pubis, but about a centimeter above it, because at this level, the obturator artery has gone inside the obturator canal. Okay, so you probably don't need to go right up to the top of the symphysis, but the UK guidelines, the American guidelines ask you to go there. So you will notice that I've not taken a very strict 18 millimeters over here. What I've done is that because this is a contrast in a CT scan, I've basically followed the blood vessels and I made sure that this space is covered. Okay, and this is a perfectly rational thing to do. There's a 7 millimeter margin over the main blood vessels, but all the other blood vessels, it's just important to cover them. That's all. So in short, this is how we would contour for a high-risk prostate cancer. We would contour we first contour the penile bulb, then using that as a reference, we start the prostate contour, then we go up, make sure that we've covered the base properly and the seminal vesicles, and then we contour the nodal volume. Okay, so I'm going to stop sharing this screen and quickly go over to the second part, which is the post-prostatectomy contour. Now, before we go there, of course, it's a question of image guidance and PTV margins. Now, very, very important, without going into any fuss, it is absolutely clear that daily volumetric image guidance is essential. If you're going to do IMRT or SBRT for prostate cancer, you cannot escape doing daily imaging, daily volumetric imaging, daily imaging with a cone beam or a fan beam CT scan. The Tata Medical Center protocol for PTV margins is 7 millimeter around the prostate and seminal vesicles and 5 millimeters around the elective nodal volume. Now, there are several institutional practices about PTV margins. My personal recommendation would be that don't keep very small margins around the prostate gland. The prostate gland position is variable. Every day, because of the rectum and bladder filling differences, there will be a variation. The variation is most in the anterior-posterior direction. So a lot of people have this tendency to give shorter or smaller margins posteriorly. That's a very, very dangerous practice in my opinion. So we keep it 7 millimeters around the prostate seminal vesicle. And for the elective nodal volume, because it's not that important, if some corner gets missed in the elective nodal volume, we keep it at 5 millimeter. Now let's quickly go to target delineation in the post-prostatectomy setting. Now, what are the indications for post-prostatectomy radiotherapy? Okay, so again, very briefly, the earlier standard was early adjuvant radiotherapy for a PT3A or T3B disease, that is extraprostatic extension or seminal vesicle involvement or positive margins. The current standard is not exactly early adjuvant radiotherapy because 3 recent randomized control trials have shown that early salvage radiotherapy is just as good as adjuvant radiotherapy, and you can actually spare radiation to about 60% of patients. So that's a huge, huge benefit in terms of patient care, where we don't really need to do that. However, it's very important to understand that early salvage means early salvage. So we have to start treating a salvage radiotherapy as soon as the PSA becomes detectable, before it reaches 0.2 or just as it reaches 0.2 nanograms per mil. And a meta-analysis of these 3 randomized control trials kind of confirm that this is a safe alternative to immediate adjuvant radiotherapy. Now, what are the boundaries of a post-prostatectomy radiotherapy? Now, the most commonly followed guideline is the RTOG post-operative guideline. Now, this was published in 2010. And what it shows is that if in the region below the superior edge of the symphysis pubis, you basically take a volume starting from anteriorly from the posterior edge of the pubic bone, posteriorly going up to the anterior rectal wall. Inferiorly, you have to go about 8 to 12 millimeters below the vesico-urethral anastomosis. Now, when they take out the prostate, they join the bladder with the urethra. So the vesico-urethral anastomosis is very important. Now, where is the vesico-urethral anastomosis? How will you identify it? Now, there are some simple guidelines that are there to identify the vesico-urethral anastomosis. So generally, it is at the area just below where you see, so you when you come down, you see the bladder, and then you stop seeing the urine. So the cut just below that, the last cut where you can see urine, the cut below that is conventionally considered to be where the vesico-urethral anastomosis is. And you have to go about a centimeter below that. Laterally, we go up to the levator ani muscles and the obturator internus. We just saw those two structures in the previous contouring. Now, above the superior edge of the symphysis pubis, you go, posteriorly. The anterior margin is the posterior 1 to 2 centimeters of the bladder wall. Posteriorly, you go up to the mesorectal fascia. Superiorly, you at the level of the cut end of the vas deferens, or 3 to 4 centimeters above the top of the symphysis pubis. And laterally, you go up to the sacrorectogenitopubic fascia. So basically go up to the fascia. Now, there are a couple of other guidelines. This is the diagram that will help you understand this. So this is from the RTOG guideline. So if you look at it, if you look at the last picture, right at the bottom, you'll see that anteriorly this goes about up, right up to nearly the top of the symphysis pubis. Here, this would be the level of the vesico-urethric anastomosis. So you go a centimeter below that. If you can't identify this properly, you have to take your contour till the cut just above the penile bud to make sure that you've covered it with margin. You go up to the bones anteriorly, go up to the rectum posteriorly, and above the symphysis pubis, you take a part of the bladder, but you don't really need to go into the rectal, and you take all the clips if they're present, and make sure that you've covered this area where the seminal vesicle was. There are a few other guidelines, the URTC guideline of 2007 and the Australia-New Zealand guideline of 2008, which more or less cover the same thing, except that in the Australia-New Zealand guideline, they want you to go inside the rectum. Okay, so the posterior is 2 centimeters anterior to the posterior wall of the rectum. So about half of the rectum is taken into the CTV. Okay, so that is where they differ. And here they're saying go about 5 millimeters below the UV anastomosis, whereas the ASTRO guidelines say, or the RTOG guidelines say go about a centimeter below the urethrovesical anastomosis. So let us go into, quickly take a look at a post-operative case. And this, I'm going to throw a challenge at you. Yep. So I'm going to magnify this. And I'm going to scroll through. So these contours are not perfect. And I want you to tell me what are the problems with this contour. Okay, write in your chat box. Don't unmute yourself because we won't be able to deal with so many people talking. But I am going to very, slowly go from below up, and I want you to tell me that how can I improve these contours. Okay, so So this was a T2N0 prostate cancer, which failed after about a year or so. And we treated this patient with early salvage radiotherapy. So now I'm going to go up a little bit and then slowly come down again. Okay, I'm going up and then I'm going to come down. The inferior border is too low. The penile bulb was included. So that's correct. So about we went a little bit into the penile bulb, so about a cut, so one cut less over there. That's correct. The rectum included, the next P again at 655 said that the rectum was included, which is not necessary. That's again correct. So according to the RTOG guidelines, you don't need to include the rectum. The EORTC guideline, the Australian New Zealand guideline, wanted you to include the rectum. But if you're following the RTOG guideline, you're correct that a sliver of the rectum was included, which was not necessary. 1 centimeter from the bulb of the penis not taken. Dr. Samir. Now, that is not correct. Now, here, you have to understand that, as I mentioned, is in the post-prostatectomy setting, if you take your lower margin 1 centimeter below the vesico-urethral anastomosis, there you will see that it goes up to the top of the bulb of the penis. Yeah, so while we shouldn't go into the bulb of the penis, we have to stay just above it. So the inferior most cut will be right above the top of the penile bulb. Okay. Again, Arati has correctly mentioned that posteriorly the rectum was taken too much. Dr. Nilesh is also correct. We've overlapped a bit with the levator ani on the sides. There was a number 166786 who is also correct. Decrease the posterior border. And a lot of people have mentioned that we've gone into the anterior rectal wall. Prostatic apex is over contoured. That's correct. It's not the apex. It's basically the in a post-prostatectomy setting, it's the vesico-urethral orifice with anastomosis with a margin. The prostatic apex is over contoured a little bit because it goes into the penile bulb. Again, a lot of people have mentioned the anterior rectal wall. Clips not included. Okay, fantastic. So what is one of the worst things that we have done in this particular case is that we've not really covered the seminal vesicle region. Now, understandably, the seminal vesicles were not involved because it was a T2 disease. However, I think we should have contoured a bit more. So we needed to go up a bit more, taking a little sliver from the posterior bladder wall and cover the seminal vesicle region and the clips. The bladder part I thought was correctly contoured. There was you're seeing a lot of bladder contoured because we, as you know, that the prostatic bed has now the bladder. So if we've anteriorly, we've gone up until the top of the symphysis pubis, which is correct. So there's no problem. Again, levators, rectum, superior border is low. That's correct. Cover the apex better. Yes. Okay. So we've more or less covered it. So thank you to many of you. I think that many of you were absolutely bang on target in terms of pointing out the imperfections. Now, nobody is perfect, but I think that it shows that you were listening and you correctly identified the problems that I showed. I'm happy to take questions.
Very nice session, sir. There are quite a few questions. Sir, one of the first question is regarding the anatomy of seminal vesicles versus vas deferens. Whether you can clarify how do you identify seminal vesicles versus vas deferens in the MRI?
Good question. No, I do think it's very difficult. So I think that it's important to identify the seminal vesicles for that. I don't think it makes much of a difference whether you can identify the vasa or not on a CT scan at least.
Okay, sir. Again, regarding seminal vesicles in high-risk disease, do we treat involved seminal vesicle to a radical dose, and is there any part of seminal vesicle which gets a lower elective dose?
That's a very good question. There have been different people do different things. Okay, so I think it's perfectly logical to treat to two different dose levels. However, in our practice, we don't do that. The reason being that I personally, when we started our service and I had to decide what to do, I wanted to keep things really simple. It's very difficult to do image guidance when you have so many volumes in the prostate gland. So I felt that it was important to keep things simple. So we don't do separate those volumes inside the seminal vesicles. It makes things a lot easier for our technologists when they do image guidance. And so far, I don't think that this has caused any additional toxicities. But that's my impression. And there are some trials which have different differential volumes, but we don't use it.
Thank you, sir. Sir, regarding penile bulb, there was a query regarding can you demonstrate the penile bulb on transversus sagittal section and explain the relation of the penile bulb with respect to the apex of prostate?
If you can appreciate over here, this is the prostate gland below the bladder, and this is the penile bulb at the bottom, the white part, and you can see the urethra going inside the corpora over here. Okay, so the penile bulb is usually below the lower border of the symphysis pubis, and if you go about a centimeter up from the penile bulb, you will hit the prostatic apex. If there was a pointer I could use, that would have been better, but unfortunately, I can't. I'm probably not very good at this. Annotate. So this is the area of the penile bulb. This is the prostate. Okay. So this is the urogenital diaphragm in between. Okay, I hope that it made sense.
Yes, sir. In relation to urogenital diaphragm, one query was: does inclusion of the diaphragm in CTV add to toxicity?
Well, certainly. I mean, if the longer your contour is inside the urethra, the toxicity, there will be a contribution of the toxicity. So this makes more. This is more importance in the radical radiotherapy for prostate cancer. So if you unnecessarily contour into the urogenital diaphragm, you will most certainly cause more toxicity. However, in the post-prostatectomy setting, you don't have much option because you have to take into account the uretrovesical anastomosis. So you really need to make sure that you come down up to the top of the penile bulb. So part of the urogenital diaphragm will get covered. Anyways, it is weak in these patients post-prostatectomy.
Thank you for clarifying that, sir. Sir, one query in regards to sparing the anterior strip of tissue at the contiguity of prostate bladder when the prostate is impinging bladder. Is it safe to spare that strip of tissue, or is it advisable to remove it in case of doubt?
That's again a very good question. I think that what I would usually do is I would take a look at the MRI, and if in the MRI it seems that that area is infiltrated by disease, I would not leave out a strip of tissue. But in most patients, it does not infiltrate into the bladder mucosa. Okay, so usually you can safely leave a strip of tissue. We have treated more than 600 patients with radical radiotherapy, and I can't remember because many of these patients are all on pretty good follow-up with us, and I don't remember seeing failures at that region. Failures, the local failures that do happen usually happen in the posterior peripheral zone. Okay, now that is my experience. So I think that leaving out a bit of tissue over a thin strip over there is safe if you have taken a look at the MRI.
Thank you, sir. Sir, quite a few queries regarding IGRT. How do you manage daily bladder and rectal filling associated uncertainties? Do you do multiple CT-based ITVs and then do plan of the day, or do you do multiple margins for small, medium, large ITVs and then do plan of the day? And whether the posterior border can be reduced to spare the rectum in case you're doing daily IGRT?
Okay, so we don't do any plan of the day. What we do is that we do daily cone beam CT or mega voltage CT, depending on which machine we are treating the patient in. And our goal is to match the prostate. Okay, so once our technologists have been with pretty good experience in doing that, because we treat a lot of prostate cancer patients. So they are able to identify the prostate and match the prostate. Now, once you've done that, you are usually safe with a 7mm PTV margin. Okay, because intrafraction motion is uncommon. It is not absent, but it is uncommon. If you are not able to do daily image guidance, then you must have larger PTV. You cannot do with 7mm PTV because there is just too much daily answer. Okay, so you really have to take bigger PTV margins if you are not doing daily IPR. I didn't have time because I really wanted to focus on target delineation, but we have done our studies and published our papers, and we've seen that it's not possible to do anything less than daily IGR. Now regarding whether we can reduce the margin posteriorly. Now, if you are going to reduce the margin posteriorly, for example, when we do SBRT of the prostate, we keep a 5mm PTV margin. Now, for SBRT of the prostate, it is important that there is a verification of the image guidance by a person who's more experienced, usually a doctor. Okay, so just technologists will not be able to do it. If you are happy to do daily verification by yourself, then you can reduce the PTV margin to 5mm posteriorly. There have been people who do a 3mm posterior margin, but without implanted fiducials, without intrafraction tracking, I think 3mm margins are a bit unsafe.
Okay, thank you, sir. Sir, one conceptual question cropping up since yesterday. Is it safe to crop out the mobile OARs like bladder, small bowel from the expansions of CTVs? It came up yesterday also, today also the same question is coming up.
Yes, that's again a controversial issue. Now, you see, it depends on how you look at CTVs and PTVs. Okay, now to me, a CTV has nothing to do with mobility. A CTV is a concept which is anatomical. So if I see that there is a bowel in one place or a bladder in one place, then I know that there cannot be microscopic disease in that area. So the CTV basically just asks you, could there be microscopic disease in that area? Now, if you are concerned about mobility of the bladder and mobility of the bowel, etc., you can play with your PTV margin. Okay, so if you can say that, okay, I am going to give a bigger PTV margin in that area because I am concerned that my when the bowel moves away from that area or the bladder moves away from that area, my target will go inside that area. So you can then expand your PTV margin into the area where you are concerned about mobility, but not the CTV. The CTV has to be, in my impression, it has to be cropped out of areas where anatomically there can be no microscopic spread.
Okay, thank you for clarifying that, sir. Sir, one question. Some of our patients come with hip replacements who will have a metallic artifact on CT as well as the replacement won't be MR compatible. So how do you manage the artifacts coming up with these replacements these days?
Again, a very important question. We are very lucky. We have a tomotherapy machine. So what we do with the tomotherapy machine is that we take a mega voltage CT scan of this patient which we can fuse with the planning CT. So our physicists are able to do that. For those who don't have that option, it is a problem. So you will find it quite challenging, and I don't have a very good solution.
Okay, thank you, sir. Sir, in relation to radical prostatectomy, if there is a pathological node, how do you address it in adjuvant RT?
Yeah, I didn't cover that. So if for when we are giving post-operative radiotherapy for node-positive disease, so for node-positive disease, there's no early salvage or anything. So you basically have to give adjuvant radiotherapy. That is what we do, although there are no guidelines, no real level 1 evidence and that kind of thing. So there we will do adjuvant radiotherapy. So, and there we will cover the nodal volume. So we will cover the nodal volumes, and earlier we used to stop at L5S1. Now we go up to the bifurcation of the aorta. So so we would cover the nodal volumes in node positive.
Thank you, sir. Sir, in case you have multiple images available, planning MRI, simulation CT, or tomotherapy, do we fuse all these images and use them to generate ITVs?
No, I don't think it helps. See, there's this increasing use of MRI for example, doing salvage radiotherapy to a sub-target in case of re-radiation of the prostate and that kind of thing. We haven't done it. So I don't believe that you can actually fuse an MRI with a CT scan properly, because they are not done at the same time. So if there was a CT MR machine, that's okay, like a PET CT machine. But the moment you take the patient from one machine to another machine, and the second image takes place half an hour later, because of the difference in the bowel and bladder, the prostate will rotate along the lateral axis, so it'll kind of swing forward like a pitch. So I feel it's quite difficult to fuse really an MR with a CT scan. So I have never even tried, but I think that if any of you, there are many people listening who have probably worked in departments where this has been attempted, you can share your experience. But I wouldn't take that effort. I think that I would rather use common sense.
Thank you for clarifying that, sir. Sir, in case of hypofractionated versus conventional RT, is there a differential dosing to the prostate volume versus the elective nodal volume in case we are practicing nodal RT?
So our practice is 60 gray in 20 fractions to the prostate plus minus seminal vesicles. And simultaneously, we give 44 gray in 20 fractions to the elective pelvic node. So 44 gray in 20 fractions would be approximately close to about 46, 48 gray if you take an alpha beta 1.5. So that is our logic. We also treat for when we do SB, actually I should say ultra hypofractionated rather than SBRT. So when we do SBRT for high-risk prostate cancer, we also take elective nodal volumes, and there we treat to 25 gray in 5 fractions.
Okay, thank you, sir. Sir, in oligometastatic setting, when we're treating prostate and let's say there are nodes also, do we treat the prostate differentially with the nodes, or do we treat the whole volume to a specific SBRT dose?
In the oligometastatic setting, what we usually do is treat just like what we would do for a non-metastatic patient. Okay, that is again to keep things simple. Now I know that, say in the Stampede paper, the dose to the prostate was a little lower, and etc. But we don't treat differently in our clinical practice. For gross nodes, for example, in a node-positive prostate cancer, I'm not talking about oligometastatic, I'm talking about node-positive prostate cancer. Gross nodes which remain after giving androgen deprivation therapy for 3 months or 3 to 6 months, the gross nodes that remain after doing the androgen deprivation therapy are usually boosted to a dose of 54 gray in 20 fractions in our practice. Why 54 gray in 20 fractions is because that roughly is 66 gray. Okay, so 66 gray is why not 60 gray in 20 fractions? When these nodes are far away from the bowel, we sometimes go up to 60 gray in 20 fractions. But when they're close to the bowel, we treat to 54 gray in 20 fractions. That is just our practice. It is not based on any evidence.
Yeah, thank you, sir. Sir, in regards to salvage RT, how much time do we wait for salvage RT post radical prostatectomy? And in terms of early versus late salvage RT, is there any criteria for hormone sensitive versus hormone resistant prostate cancer monitoring and PSA monitoring?
So I think that the terminology has to be clarified. I think what the question is probably trying to the person who's asking the question is trying to ask is that, do we give immediate adjuvant or do we give early salvage? There's no such thing as late salvage. Late salvage is not a good idea. So there's no point. If we are doing salvage radiotherapy when the PSA is 2 or 3, then you've already lost the battle. So don't bother about it. So the question is, are we going to give adjuvant radiotherapy or are we going to give early salvage radiotherapy? Adjuvant radiotherapy is after surgery. You treat based on pathological risk factors, and there people would usually wait for about 3 months before they gave the radiotherapy, because giving radiotherapy too early has been shown to compromise urinary function. So you have to wait for about 3 months before doing the radiotherapy. In early salvage radiotherapy, you basically just keep monitoring the PSA. And if the PSA becomes detectable and then reaches close to 0.2 nanograms per ml, that's when you start the early salvage radiotherapy. Now, what about hormonal treatment during this time? Hormonal treatment is an option for patients who are getting early salvage radiotherapy. It is not really used when we are doing adjuvant radiotherapy. Okay, so for early salvage radiotherapy, we usually treat with 6 months of ADT. Okay, so 6 months of ADT and radiotherapy is what our usual practice is. And therefore, we start the ADT first when the PSA reaches 0.2, and then we give the radiotherapy 3 months later.
Thank you, sir. Sir, since the issue of clips came up, how do we differentiate between prostate bed clips and hemostatic clips? And in case of discrepancies, would you include hemostatic clips also in the post-op tumor bed volume?
I think I'd use my common sense, and if it's in an area where the cancer or the seminal vesicles could be, then I would include it. But I wouldn't. There are some patients, for example, where the hemostatic clips are right at the edge of the pelvis. They are like right beside the muscle, for example, the levator ani on the pelvic diaphragm. There I wouldn't go up to the. Or if I have a doubt, I'd ask my surgical colleague.
Okay, thank you, sir. Sir, one of the final questions: what dose constraints would you use for OARs in your clinical practice?
Right, I should have put a slide on that. Now let me see. I'll try to find it. Just give me a second. This is not what I want to show this one. Can you see my screen? So this is our protocol. Let me see where the dose comes from. So these are our dose constraints on for the 60 gray and 20 fractions at the moment. Okay, so we've got dose constraints for various levels. You can quickly screenshot or take it.
Sir, can you show your protocol?
Can we share our protocol? Yes, we can. So you will see, interestingly, that there are some percentage or the relative volume constraints and some absolute volume constraints. So my colleague, Dr. Moses Arun Singh, he and I did a study when he was quite a few years back now, where we looked at acute toxicity correlates, and we found that the absolute volumes were better predictors of acute toxicity than than relative volume. So these are the cutoffs we found. We have a paper on that, and so that's why we also see what these volumes are. So the 53 gray volume has to be less than 9.7 cc. And we also hypofractionate in the post-operative setting. This is not based on any level 1 evidence, but the increasing number of hospitals are doing it. So these are our constraints for the post-operative setting of 55 gray and 25. And this is with the dose constraint for the SBRT. Actually, instead of going into a specific hospital's dose constraints, I'll tell you the logic behind these dose constraints. So what we did was that when we were starting off, there were no dose constraints. Okay, we have been doing hypofractionated radiotherapy for 10 years. So there were no real dose constraints. There were dose constraints in trials, and every trial had a different dose constraint. So what we did was that we developed our own dose constraint. So what we did is that we took the contact dose constraint, and then we found dose correlates. Because it was hypofractionated, you have to find that, for example, 70 gray in conventional fractionation, what is the corresponding dose in hypofractionation. Okay, so suppose 70 gray is equivalent to say 57 gray or something like that in 20 fractions. So for the rectum. Now, say if the contact constraint is 30%, you reduce that by a third. Okay, because the contact constraints are very easy to meet. So you don't want to go up to contact constraint. So if it's 30%, you make it 20%. Okay, and you will find that in the vast majority of patients, you will be able to meet these constraints very easily. So we actually developed our constraints like that. So these are not hard and fast. They are not the best constraints. In fact, if you want constraints, I would say that evidence-based constraints will be, there is a paper from the UK CHIP group, which was published about a year back, I think, where they have shown in their 3,000 odd patients or 2,000 something odd patients who were in the CHIP study, they did a very, very detailed analysis on toxicity and dose constraints. So if you're doing 60 in 20, then I think that those dose constraints will be the reference standard which you should try to use. But I'm also happy to share mine.
Thank you, sir. Sir, one question. In case of upfront androgen deprivation or hormonal therapy, if the prostate volume reduces, do we treat the baseline volume with the baseline MRI, or do we stick to the reduced prostate volume?
We stick to the reduced prostate volume.
Thank you, sir. Sir, one question regarding any role of hydrogel rectal spacers or any other rectal spacers to reduce rectal toxicity?
There is very good evidence for use of hydrogel rectal spacers, but It depends on whether you want to use them or not, whether your patients can afford it, whether it's logistically an option for you. So if all of these are options, then you should use it because there's level 1 evidence for the use of hydrogel spacers. In our clinical practice, I and most of my colleagues, we believe in simplicity. So I don't think that I want to tell any of the prostate patients that no, now get spacer introduced into your go get this thing. I feel that I can do without it. But there is very good evidence for the use of hydrogel spacers. So if your patients have the money, if your interventional guys have experience, please go ahead.
Thank you, sir. Sir, it seems a lot of candidates are interested in discussing planning also. So maybe it may fall out of the purview of this class. Might be able to conduct conversation on planning probably. Planning and plan evaluation.
Yes, that we can do. Not a problem.
Okay, thank you. So that concludes most of the questions today, sir.